As I said, this is our second webinar series in the Ph.D. webinar. This is the second webinar in our webinar series of See Everything at Once. And today we will be focusing on endophenotyping in sleep. And I have great guests with me today, and I will introduce them shortly. But before I start, I wanted to let everyone know that I'm really excited about this topic. I think this is one of the most important topics facing us in the world of sleep medicine. We have been talking about going beyond the IHI, going beyond, diagnosing everyone in the same manner, and this is clearly a step into the right direction. We are getting technology that actually allows us to perform respiratory endophenotyping and endophenotyping on OSA patients. And today, I want to start by introducing, oh, sorry, I'm getting some feedback that it might be difficult to hear me. We will try to fix that. But I'm going to start by introducing Dr. Jón Skírnir Ágústsson, who is part of our ADAR team. He will start by explaining a little bit about the endophenotyping modeling that we have been doing and what phenotyping and endophenotyping in sleep actually is, and how we can see that in our software, for example. Then I am very proud to present two excellent doctors from Taiwan, Dr. Wan-Ju Cheng and Dr. Lang-Wen Han. And they will follow Jón Skírnir's presentation with a presentation on their own research in endophenotyping in OSA. But without further ado, I'm going to present Jón Skírnir to join me here. He is just standing next to me, and he will start this webinar formally.
Yes, thank you. Welcome all, and thank you so much for joining. My name is Jón Skírnir, and I'm the director of a team that we call Analysis, Data, Automation, and Research, or ADAR for short. I wanted to tell you a little bit about what we've been doing with endophenotyping, and I see that we are having a little bit of problem sharing the slides.
Wait a second.
Yeah, and what I want to tell you about is maybe a lot of people have heard about the phenotyping of obstructive sleep apnea, and it's a hot topic in research currently. But I don't know if everyone is really deeply aware of what it means and what we are actually talking about when we're talking about the endophenotypes of sleep apnea. What we are thinking about in this respect is that the endophenotypes are explaining what is the physiological cause of sleep apnea. And anyone who has worked with sleep apnea knows that sleep apnea is not just only one thing, but there are actually many reasons which can cause the sleep apnea events to happen. So to try to define what it is, I of course just went to Wikipedia, where an endotype is defined as a subtype of a condition, which is defined by a distinct functional or pathobiological mechanism. In the endophenotyping of sleep apnea, sometimes people talk about this as treatable traits, and we're seeing a lot of literature where scientists are trying to target specific causes of sleep apnea with specific treatments other than CPAP. And the endophenotypes which we are focusing on are the upper airway collapsibility, or how easily the airway closes. And here on the bottom of the screen, I just showed an example of what it looks like when someone has a highly collapsible upper airway. And this is what you would think about as the typical severe sleep apnea patient, which has repeated severe sleep apneas with huge desaturations. The next one we're thinking about is arousal threshold, or how easily do people wake up from disturbances in ventilation. And a case, what I found, which is probably like a typical person which has a low arousal threshold and wake up easily. These are people who have small disturbances to their ventilations, and then they are followed by arousals. And there are no drops in the SpO2 signals. So these are typically your patients which have hypopneas and arousals. They would probably have low arousal thresholds. The third endophenotype is compensation. And this one was really hard to find a picture to explain what it is. But this is describing how actively you can recruit muscles to open up the upper airway when it collapses. What I found here is an example of a patient which is sleeping in non-REM sleep, has a collapsible upper airway, but manages to maintain ventilation when they have muscle tone. When the patient then transitions to REM sleep and loses the muscle tone, we start to see the apneic events happening and becoming more severe. So this is maybe highlighting a little bit what this is measuring. And the last one is loop gain, and loop gain is related to the control of the feedback mechanism of ventilation. And we typically see these in patients who have a hard time maintaining stable ventilation. And I wish I could show you more of the study because it was actually quite interesting, the one I found. What we see there is that the flow starts out, and in this study, it starts out as quite regular. Then it goes a little bit, starts to have this modulation. So the patient is having trouble regulating the ventilation. And then as soon as they have the first sleep apnea, we can start to see this kind of pattern of periodic breathing, where they are hyperventilating, then hypoventilating and hyperventilating, and they just cannot manage to stabilize their breathing again. So these are the 4 endophenotypes that we're mostly focusing on. Of course, we did not invent the endophenotypes, and we would not claim this. We started down this path with a very nice collaboration with Professor Andrew Wellman and Scott Sands in Harvard. And they've been working in this field for a long time. And the first paper that caught my eye was published in 2011, where Andrew Wellman was describing a method of measuring and modeling the physiological traits causing obstructive sleep apnea. And what he's doing then is he is giving people an oronasal mask to measure ventilation. He's applying CPAP, and even using an esophageal catheter to measure the intrathoracic pressure. And on the right side, you see a picture of me with the equipment, so how it looks. So you can easily imagine that this is something which is difficult to do in a clinical setting, and it's not very comfortable for a patient. What is missing on this picture is, of course, the Ph.D, and then also the connection to the CPAP. But this is how people were supposed to sleep, so that you could get the endophenotyping traits. But what they did then following this is that they were trying to develop methods of getting the endophenotypes using just a standard polysomnography. And really the trick there is to measure ventilation accurately. But in 2015, they published this paper using a MATLAB algorithm called PUP, phenotyping using polysomnography. And following this, we've been collaborating closely with them. And earlier, or in 2020, we actually published a paper with them on our implementation of the PUP algorithm, which we call PUP-Py, because we write it in the programming language Python, and then it's customized to end everything with Pi. And we get this very nice acronym. But in this paper, we show that we could actually implement their methods from first principles in a different programming language. So we are kind of validating that their implementation is correct and deploying it in a cloud setting so that we can actually grant scientists like Dr. Wan-Ju and Dr. Han access to the method so they can actually apply it on their own patients and do their own research on endophenotyping from their PhDs. So with this, I think my introduction is done, and I hope you just enjoy the rest of the webinar.
Thank you. Thank you very much, Jon. And just not to interrupt you with my gibberish here, I'm going to introduce the next speaker here, Dr. Wan-Ju Cheng. She is going to be presenting their own research on the topic. Go ahead.
Good evening and good morning to some of you. I'm talking from Taiwan, and I'm a sleep specialist and psychiatrist. And Dr. Han is the director of our sleep center. Today, I'm going to share with you our experience to collaborate with the Nox company and using their technique called PUPPY to identify endophenotypes of our OSA patients. At first, Jon has given us a quite clear picture of the history and current state and past studies of how endophenotyping has been noticed and getting more attention recently in the literature. Here we have the 4 main identified endophenotypes, which is upper airway collapsibility and muscle responsiveness, loop gain, and arousal threshold. Initially, these endophenotypes can be very difficult to identify in clinical settings because they don't use standard PSG equipment such as esophageal manometry, and it also causes discomfort to the patient. So we cannot use it in every patient, and it's difficult to put it into everyday clinical practices. And as Jung has mentioned that later, the team from Harvard has developed some way to that was less invasive to measure the 4 endophenotypes. The first thing is CPAP titration. They used manually dropped CPAP pressure during the study and creating a apnea or hypopnea, and then measure the ventilation responses when CPAP pressure is reestablished. But there's still some drawback in such a method because it's quite labor intensive. One technician or sleep specialist has to keep on site, and as Jung has said, it is quite uncomfortable. So we're not sure if patients can tolerate CPAP so well during the test. So the PAP method, I think it's really a breakthrough because it uses standard PSG, and they have established a model to retrieve the 4 endophenotypes without any additive equipment or invasive procedures. But there's a still small limitation, which is that it's not very approachable, very accessible to sleep centers other than the Harvard Sleep Center. So we are very thankful for the Nox team who has developed the Python implementation of the PUP method. And I'm not going to go deep in the technology aspect of this, but it really pushed further because with this technology developed by the Nox company, we can also retrieve the 4 endophenotypes easily. So if it's very easy to approach now, what we are going to do next is we would like to look at the demographic characteristics of OSA patients and its association with the 4 endophenotypes. For example, our old or young patients, or men or women, how do they have the endophenotype distribution? And also their clinical symptoms. We have seen in the literature that their OSA patients may be insomnia, or they may be hypersomnia, or they may have no symptoms. And what's the relationship with those clinical symptoms with the endophenotypes? We haven't tested yet. And most importantly, in clinical practices, we want to have personal treatment for our patients. These 4 endophenotypes may contribute to different treatment outcomes. And there has been some reports emerging in recent years. And last but not least, we also wanted to know the relationship between these endophenotypes and comorbidities and mortalities in long term. So,
Dr. Cheng, can I interrupt? It seems like you are presenting the presenter mode of the PowerPoints. So we're seeing if you could.
Oh, okay. I shouldn't use that mode, right?
Yes, I just wanted, yeah. So if we can.
Okay, is this better?
Yeah, I think either that
okay.
or, yeah, I think this is good.
Okay, thank you. This is where our sleep center locates. It's in East South Asia, in the central Taiwan. We are called the China Medical University Hospital. In our sleep center, patients are referred from physicians of all specialties. And we have done Ph.D. and CPAP titration studies, and they are both covered by National Health Insurance. I know this is not very common in the world, so because it's covered by health insurance, so home Ph.D. market is not very big in Taiwan. Everybody does Ph.D. in the laboratory. And the ethnicity is mainly Chinese, Han Chinese in our sleep center. As to my knowledge, also studies concerning this ethnic group is still quite rare. So we would like to study, have more study in this group. We have PhD data collected since 2007, and we have 2,000 PhD cases annually. We accept all age groups from infants, from even infants to very old person. And we have several certified technicians who can manually score our PSG and CPAP titration study. So the next topic is that can treatments be optimized based on endophenotyping? It is exactly what clinicians care about the most. I have checked the literature now, and we have found some reports about how treatments can be specified for the endophenotypes, for example. Patients with very poor upper airway muscle responsiveness, hypoglossal nerve stimulation would be a good choice for them, and also medications such as atomoxetine and oxybutynin. And patients with high loop gain, we would like to stabilize their respiratory patterns, and acetazolamide is a good choice. And in patients with low arousal threshold, many studies have shown that sedatives can help these people to sleep better and reduce their arousals during normal sleep or even CPAP with CPAP treatment. And those with upper airway compromised conditions, such as a very narrow or crowded upper airway, high collapsibility patients, we would feel like they would be suitable for upper airway surgeries. And here I'm going to present a very preliminary results from our sleep center. We have collaborated with the Nox Research Center, and they helped us to analyze the endophenotypes of our patients. So we have recruited 558 patients who are older than 20 years old from May 2020 to August 2021. Among these patients, 310 of them had a AHI larger than 15 per hour. And among these patients, about 46% had received a CPAP titration study in the same sleep center, and that's 143 of them. The duration between PSG and CPAP titration study was 45 days in average. And we finally analyzed those 143 patients, and we wanted to see how their endophenotypes is associated with the sleep architecture improvement and their optimal CPAP titration pressure in this condition. So here I present the demographic characteristics of these patients. The average age was 43 years old, and 14% of them were women. The waist circumference was 100 centimeters, and neck circumference was 40 centimeters. The BMI was averagely 31, and they had an AHI averaged 49. So we can have a picture that this is a group of middle-aged, quite obese patients with male predominant, and they have severe OSA. In these patients, we have retrieved their endotypes. And I can assure you that with this 143 sample, the PUPI method can retrieve the endophenotypes within 1 week. And that's a really high efficiency compared to the traditional methods. And we have the mean value of arousal threshold, which is shown as the chemical drive right before EEG arousals and presented as the percentage of eupnea. The average value is 159% of eupnea. And loop gain, the average loop gain was 0.6. So it's smaller than 1, which means that their ventilatory response was smaller than the ventilatory disturbance. And the collapsibility is represented as 100% minus ventilation at eupneic drive. And the average value here is 27.5% of eupnea ventilation. The upper airway gain was minus 0.1, which means that this is smaller than 0. So, which means that our patients don't have a very good compensation ability, slightly lower than 0. And how it was generated, I show it here. And here's the optimal CPAP pressure we retrieved by technicians. They titrate the pressure at the night when the CPAP titration was performed. And I dichotomized the patients by the 4 endophenotypes. For example, I separate the patients into high arousal threshold and those with low arousal threshold. I compared their optimal pressure, and we can see that patients with a higher arousal threshold may they reached a higher optimal CPAP pressure at the end of the study. And I think this is quite reasonable because patients with a higher arousal threshold, they are less easier to be aroused by like high CPAP pressure. And so I would say they have a better tolerance with CPAP pressures. And patients with low arousal threshold may not be so tolerable to high pressures because a higher pressure can cause them to wake up. And then we see the loop gain. Patients with a high loop gain also reach the higher optimal CPAP pressure. Okay, and well, we would like to explain this like patients with a higher loop gain, I think they have a more unstable respiratory pattern. So a CPAP would, we would need a higher CPAP pressure to stabilize their respiratory pattern. And it is also very reasonable like that patients with higher collapsibility would need a higher CPAP pressure. And patients with a higher upper airway gain also need a higher optimal CPAP pressure. This finding was unexpected because theoretically, patients with a higher upper airway gain usually can protect them from total apnea. It seems to be a good trait, but why would they need a higher optimal CPAP pressure? After discussion, we think that patients with good muscle response, when we titrate CPAP pressure, with each unit of pressure we give him, we remove the negative pressure stimuli to the upper airway muscles. Okay, so this reduces their upper airway muscle activity. So it's a quite counteracting condition in the upper airway. So we would need to, the pressure would need to first replace the endogenous muscle activity, and then we can overcome the upper airway obstruction. So this would explain why patients with higher upper airway gain may need a higher optimal CPAP pressure. And in this model, I used linear regression models, and I have included age, sex, BMI, and AHI as the adjusted variables. So this is quite interesting finding that I would like to share with you. Another finding is that we all know in OSA patients, in the first line of CPAP titration, they should have REM rebound and slow wave sleep rebound. We would like to check how the sleep architecture changed when they wear CPAP. So here I compared individually their sleep architecture between PSG and CPAP titration study. So this is a short-term, very short-term outcome. We would like to know the long-term outcome, but not yet. And here I also, as the first result showed, I also separate the patients into high-level endophenotype group and low-level endophenotype group. For example, in the arousal threshold effect group examination, I checked the differences in sleep efficiency between PSG and CPAP titration studies. So here the sleep efficiency increased like almost 5% in CPAP study compared to PSG study. So you can see in the whole graph, almost everyone had improvement in their sleep architecture. So that's quite reasonable. How about those with high arousal threshold and those with low arousal threshold? Okay, so from this histogram, you can see that patients with higher arousal threshold, they have more improvements in their sleep architecture compared to patients with lower arousal threshold. And it has reached statistical significance in the REM percentage. Similarly, when I examined the loop gain, patients with a higher loop gain, they also had a more improvements than those with low loop gain. And those with high collapsibility, well, this is most easiest one you can imagine, that patients with a higher collapsibility, they have a very large improvement in their sleep architecture. Whereas those with low collapsibility, I would say they have minimal improvement in their sleep architecture. And in three indicators, including sleep efficiency, slow wave sleep percentage, and REM percentage, they all show significant differences statistically. And in the upper airway gain effect, I see those with higher upper airway gain also had more improvements in their sleep architecture than those with low upper airway gain. Well, so this means that patients with higher upper airway gain compared to those with lower airway gain, they may need a higher optimal CPAP titration pressure. And patients with high collapsibility, high arousal threshold, high upper airway gain, and high loop gain, they have larger improvements in sleep architecture during CPAP titration compared to Ph.D. study. Well, we have tried to this is our first try to see the effect of endophenotypes and how it affects the titration effect and results, but there are certainly many limitations in this study which we wish to address in the future. So what's the next step? Okay, we found that we would need large cross-country population studies, both in different ethnic groups in Asia and in Europe. We would like to know what the distribution is, and then we can define what is high endophenotype value and what is a low endophenotype value. Because now we still have a quite small sample. We can't say that, for example, how high is a high arousal threshold? Should it be 150% of eupnea or 100 or 120%. We don't know yet. We will need a big sample study to tell us this. And second, in the result I show you, I dichotomize the patients with the 4 phenotypes respectively, I mean separately, but there are certainly some interactions between them. For example, how would a patient with high collapsibility and low arousal threshold differs from a patient with high collapsibility and high arousal threshold? We haven't known that yet. Yeah, so next step, I would like to examine the interactions between those endotypes, how they influence each other, and how this interaction associate with symptoms and treatment outcomes and mortality and morbidities. Okay, so this is my preliminary results that we have collaborated with Dr. Einstein, Vincent, and Young, Augustin from the Nox Research Center, and also Dr. Scott Sands from the Harvard Medical School. I would like also to thank Dr. Hung and all our technicians who manually titrated and scored all these studies for us. And that's all. Thank you.
Thank you very much. So we are ready for questions. We have some 10 minutes for questions, but I'm gonna start out with the first question because this is the one that interests me the most. And you touched a little bit on this at the end of your presentation. This is the interaction between endotypes. Have you seen any, clues on which endotypes are more connected to each other than others? You are muted.
Sorry. Okay, thanks for Snorri. This is a great question. And since we cannot just separate our patients into like numbers or group, so I have tried to use clustering methods to see how these 4 endotypes would some would segregate together and some are some counteracts. And initially, I find there could be at least 2 groups, and one group of patients had a high collapsibility and high arousal threshold. Well, this group clinically, we can actually imagine this group of patients. They have a severe OSA and they don't wake up even with very long apnea durations. And they may be very suitable for CPAP titration study, yeah, but we don't yet know. And there's another group we often see who have a low arousal threshold and high loop gain and with low to moderate collapsibility. Well, these patients they present more insomnia symptoms, and CPAP is quite difficult for them. They are very sensitive and they do not tolerate CPAP very well. So this is initially what I see from the clustering analysis. Well, but I think we can do it in more detail to see if these 4 endophenotypes, they are not just individually contribute to the AHI. Maybe there are counteracting effects. Maybe there are additional effects between them. Yeah, but well, I don't really have a very empirical evidence for this question. It's just from some experience and very preliminary statistical results. I would like to share it with you.
Yeah, thank you for this answer. And while you were answering, I started the poll here. So I'm going to share the results with all of you, and we're going to discuss some of this. So we're always interested in seeing you know, if people are moving to type 2 studies, I mean, making endophenotyping more accessible. You mentioned that in Taiwan, most of the studies are performed in an in-lab environment. Is that something that is going to change, in your opinion, in the coming years, or is this are we still far away from that, performing studies in the patient's home?
Well, yeah, I'm also interested in whether this puppy method can be used in home PSG. Yeah, because in Taiwan we have a national health insurance which covers almost everything. So patients come to sleep center with almost zero pay. So everyone would choose to have a laboratory PSG. And with laboratory PSG, there are many advantages that our technicians can provide standardized practice, and they can manually score these results. So it's perfectly suitable for the puppy method. Yeah, and I don't think it's gonna change in short time, because home PSG in Taiwan have to be paid out of pocket. So I think most people would still choose to do the study in the laboratory. But like in some other countries where standard PSG in lab is not covered by insurance, yeah, people would choose to do home PSG. And is it possible to upload their own home PSG into the cloud and they can see their own endotype?
Yeah, this is maybe a question to us. And Jon, do you want to take your future guess on that?
No, it's very hard to predict the future, especially in medicine. But what we're seeing is there is, of course, more interest in doing home sleep studies, particularly now after COVID. It's kind of pushed us more into that realm. It's very interesting also to monitor a little bit what treatment providers are thinking about, because we start to see more and more treatment or companies who are developing alternative treatments to sleep apnea. And we're seeing, for example, pharma companies starting to think about this, companies making implants, of course, oral devices. So it's going to be very interesting to see how, or if this will be adopted as standard clinical practice, and what will be kind of the requirements there.
There's actually, I want to take one of the questions here, and please, everyone, feel free to write your questions in the Q&A field here. There's actually one very interesting question, because there is the question regarding patients that have recurrent hypopneas and low number of apneas on a home sleep apnea testing. And the question is really, are those patients, do they have potentially low arousal threshold? And is this an indication of that? Because, I mean, obviously you wouldn't see the arousals lacking the EEGs. But is this a clue that people that are undergoing HSAT with recurrent hypopneas and few apneas, is this an indication of low arousal threshold? What's your opinion on that?
Well, yes, before we can do the endophenotyping using the PUP or puppy method, one method by Dr. Edwards, I think it's Dr. Edwards and his team, they have tried to use the hypopnea fraction and the nadir, oxygen saturation, and AHI, these three variables to estimate arousal threshold. And there's a mathematical model to calculate that. And yes, we think that a higher hypopnea fraction, which means that in the total hypopnea and apnea counts, there's a high fraction of hypopnea rather than apnea. Probably, but I wouldn't say it definitely is, but it does suggest a low arousal threshold, because the patient seems to wake up before the respiratory event goes into a total apnea. Yeah. So, but this method or this guess is I would say is very accurate, because it considers only one variable, and there are still many other factors that would influence the arousal threshold. Okay, so For example, in our endophenotype, those 4 endophenotypes, I would say loop gain actually would also influence the arousal threshold when you have a very unstable respiratory pattern. I always think maybe it will exacerbate the arousals, frequent arousal problem. So we have, yes, before we have these puppy and pup methods, clinicians always guess this. We guess if the patients have low arousal threshold from the very preliminary data. For example, the hypopnea fraction. Well, my answer is yes, but it's not as accurate. And since we now have the great methods, yeah, I would like to go forward.
Yeah, we all would. We have one more question here, and maybe I would want to add one more comment to that. So the question is here: what is the AHI to start treatment by CPAP treatment? If you have snoring patients that potentially, and maybe if I may add to this, if you have snoring patients that don't meet the criteria for CPAP treatment of potentially 15 and above, can we use this to treat more patients below the threshold with CPAP? Can we use endophenotyping to either get more people treated with CPAP or alternative methods?
Wow, this is a great question, because we are really going forward from a single indicator of AHI to more sophisticated endophenotyping. Yeah, I think this is a good idea that maybe someday we will know not only the AHI, we will know, oh, this patient, he actually has a high collapsibility and he has a high arousal threshold and high loop gain. Well, this is a guess from our preliminary result. And even though he doesn't have a very high AHI, but he's very suitable for CPAP treatment compared to other treatments. Yes, that is the goal of the whole thing, the endophenotyping for patients.
And if I add a little bit, is that we talk about these 4 endophenotypes, but for example, we are not discussing, for example, snoring or mouth breathing, and there are other mechanisms which can also be related to sleep apnea or disturbed breathing during sleep, which we are not addressing at the moment. So I think there's a lot of things that are still to be done.
Mm-hmm. Absolutely, and I think with those words, I'm gonna put an end to this fantastic session. Maybe if we have actually one more question. Let's try to answer this one. Do you change your therapeutic practice now after your study concerning CPAP? Yes, no, according to phenotypes, or concerning the CPAP pressures? So this is a question: have you already made some changes, even though it's early days in the endophenotyping?
Yes, yeah, we hope to. I suppose that someday we will have even very fast real-time responses from the analysis, the Python system, that we can retrieve their endophenotype very quickly. Well, it's not that fast now, but I surely will be realized someday that we can tell the patients very fast, because patients always come maybe 1 or 2 weeks later than after their PhD study. So it will has to be faster results, so we can inform our patients the choices.
All right. Thank you. I'm going to end the webinar just to be mindful of everyone's time. As per usual, the recording will be made available to you attendees, and you're free to send us questions if you have any regarding this and endophenotyping in general. I'm also going to tell you about the next webinar that we are hosting. It's actually next week already, so there's not that much time to sign for that. But in that webinar, we will be discussing the future of PSG and future of in-lab polysomnography in sleep. So thank you, everyone, and a special thank you to you guys, the presenters. It was a pleasure having you, and all of you attendees, thank you for attending, and I'll see you next time. Thank you. Bye-bye.
Thank you. Bye-bye.